Good afternoon. I'm Paritosh Sharma. I'm a vascular surgeon at 108 Harley Street. You may have joined us for these CPD snippet sessions previously. And during these times of the pandemic, we thought it was going to be a good idea to have a digital platform and bring about these snippet sessions. Today, I'm going to be talking about the diabetic foot, a problem that I face quite regularly, and we see a lot of patients with these problems. So I thought it was going to be a good topic to talk about. Why is this important? I'm sure you can see the numbers on this slide, but up to 25% of diabetic patients will develop foot problems. There are over 100 million diabetic people across the world at this time. A significant majority of them are type 2 diabetic patients. The annual incidence of diabetic foot ulcers in the UK is close to about 10%, so a very significant number. And the significant part of this is that up to 80% of these patients can progress to a significant or a major amputation. Diabetic foot ulcers carry a 5-year mortality rate of up to about 25%, and this can go up to 45% at 10 years. So it's a significant problem that we face in our society. So it's important to treat these patients and recognize them early and treat them early. The pathophysiology of diabetic foot ulcers is essentially twofold. They're neuroischemic ulcers. A significant proportion of them, up to 60% of patients with diabetic foot ulcers, will have an element of neuropathy. And what this means is essentially the hyperglycemic state at a very biochemical level will reduce the myoinositol synthesis in nerve cells, which is essential for nerve conduction. Hyperglycemia also leads to reduced NADPH stores, which you may, if I take you back to medical school days, is responsible for most cell activity. All of this essentially means there's increased oxidative stress on the tissues, and the nerve tissues. We know that all three components will become affected, both the motor, sensory, and the autonomic components. Loss of sensation can lead to traumatic ulceration, with the patient being unaware of increased stress or pressure at particular pressure points in the foot. Motor impairment can bring about an imbalance between the flexion and extension aspects, as you can see in the picture here, clawing of toes, and they can bring about abnormal bony pressure points. So these patients can develop ulcers at abnormal points in the foot as well. Autonomic impairment can lead to a loss of sweat gland functionality with increased dryness, fissuring of the skin, especially heel cracks, and these can lead to development of infection and problems as a consequence. Up to 50% of patients with diabetic foot ulcers will have concomitant peripheral arterial disease. And the important thing here is that the arteries that tend to be affected in these patients tend to be below the knee. This picture here depicts a normal artery on the left, as you can see, a normal caliber with good flow through, whereas in the atherosclerotic artery, you can see that the lumen is narrowed, and hence you get a reduced perfusion into the foot, leading to poor healing and foot ulcers. At a biochemical level, there is endothelial dysfunction, a reduction of nitrate oxide production, which leads to vasoconstriction, reducing the blood flow into the feet. Also, we know that diabetes can lead to an increased production of thromboxane A2, which induces a prothrombotic state. These patients also have concomitant risk factors, so they may be hyperlipidemic, they may be smoking, they may have hypertension, but we also know that diabetes in itself lends to an increased propensity of these patients to develop atherosclerosis. So all of these factors together will mean that you have a reduced blood flow into the foot, and hence it is important to recognize these patients early. You may have also heard of the term Charcot's arthropathy. And essentially, I've got a picture here of a normal foot. As you can see, the normal foot arch here. In a Charcot's foot, this is all, you can see the difference here, that there is, because of repeated stress injury to the weight-bearing bones in the foot, you get a deformed foot. This is a picture of a Charcot's foot, and as you can see, they are warm to touch, and that's because of the autonomic dysfunction, that they have an increased blood supply. So there is also an alternative theory. So the theory that I originally referred to is the neurotrauma theory for developing Charcot's. You also have a neuroischemic theory leading to the development of Charcot's, which is essentially an autonomic dysfunction which leads to an increased blood flow into the foot, and that leads to an imbalance between the remodeling of the bone and leading to an osteopenic bone, which is more likely to fracture. And hence you get this presentation. Well, how would you assess these patients? So essentially, take you back to your usual history and examination. The history should be specifically targeted at picking up diabetic complications. So if you have a history of neuropathy in the past, if you have a history of previous ulcers, if these patients claudicate. So it's important to ask all of these questions to these patients. Do they have a smoking history? On examination, again, apart from your usual examination of the legs, it is very important to inspect between the toes, because they may have hidden ulcers, areas where the skin has fissured or developed cracks. If they have bony deformities, if there is a temperature difference between the feet, an assessment of their pulses in the feet, and sensation. So apart from the usual light touch assessment, there are several tools which are available that we can teach even lay people to assess. An important tool that we use is the Ipswich touch test, which essentially means a light touch with your index finger on the first, third, and the fifth toes. And if the patient is insensate at more than 2 of these points, we consider that as a marker for patients to be neuropathic. How do we manage them? Early recognition and patient education goes without saying that we have to educate these patients about proper foot care. And also, it would be good if we could sort of fit them into local foot care services, so that somebody can keep a good eye on these patients on their feet. Expeditious referral, so early diagnosis and early treatment. I've got some pictures here of the diabetic foot. You can see that this person has a tracking infection with a tip which is necrotic. They needed urgent antibiotics, hence early assessment. If we stop it early, we can stop this progressing. Up to 84% of patients progress to amputations, and up to 40% of these amputations are avoidable as long as we pick things up early. On the right picture, you can see an innocuous looking small wound on the hallux, which with appropriate treatment actually is healing very well. As a vascular surgeon, I have to tell you about the treatments that I afford that can bring about increased healing. So these 3 pictures are X-ray images or fluoroscopy images of, as you can see, sort of arteries which are diseased, and there is very minimal flow into the foot on the picture on your right. So this patient underwent an angioplasty all the way down into the feet. As you can see, there is improved blood flow to the below the knee vessels, the trifurcation, the blood flow is improved. We've gone in and plastied the posterior tibial artery here and the anterior tibial leading into the dorsalis pedis with a wire in the pedal arch. This is the post-angioplasty picture, which you can contrast with the original picture that I showed you of the foot. This is important. We try and be aggressive with these patients to improve the blood flow into the affected part of the foot. If the angioplasties don't work, this is a picture of a patient of mine who underwent a distal bypass. As you can see, I've plumbed their long saphenous vein onto the artery up here and then tunneled it all the way down into the pedal artery here. That's the end of my talk today. This slide is about referrals, and if you had any questions, please feel free to contact us. Thank you.